everyone, and welcome to On the Horizon in Healthcare. My name is Dr. Beth Brooks, and I'm the clinical advisor here at Vivian Health. And I am so excited today to be talking to my friend and colleague, Dr. Jennifer Mensik Kennedy. And Jennifer, I want to read her bio so I don't make any mistakes, is the new president of the American Nurses Association. Her term started this past January. And she has been very active with the American Nurses Association, has served on the board, has served on the Audit, Finance, Investment Committee. She's also been the president of the Arizona Nurses Association. And I think what's fabulous and interesting and terrific about Jennifer's background is she's both has the clinical background, having been an assistant director of clinical care at Banner in Arizona, but then she also has experience on faculty and has taught graduate level courses in health economics at Oregon Health and Science University School of Nursing. And that's why she and I get along, because we can talk numbers. And some of the questions I have for her today are very policy related, because so much of her role, or a large component of her role as president of the American Nurses Association, is policy and advocating on the behalf of nursing and nurses. So I want to talk a little bit about your perspective, Jennifer, on why aren't nurses visible, or how could we become more visible with consumers, with families? So often it's medicine, and we need and love our colleagues in medicine, but the nurses are behind the scenes, and then we're also not viewed or not seen. And so talk a little bit about why nursing is an expense, and how do we start to make nursing more visible and more demonstrating our value.
No, absolutely. Great questions. I always start with words sometimes matter. And because when we think about, who can do what to make a change, there are some things that nurses individually can do. And then there are things that we're going to need professional organizations to work on, and things that we're going to need Congress to work on to make those changes occur. And starting with the nurse themselves, I would ask people when they say, what field are you in or what do you do, to say you practice nursing. And quite often I hear nurses say they practice medicine, or they're in the medical field. You're not in the medical field, you're in the healthcare field, you are in the nursing profession. And so I think having even some slight saying words even at that level starts to make a difference when people hear that. Because when the nurse says, I work in the medical field, then we just continue to put ourselves into a box. Mm-hmm. Second, we're going to need nurses to go out and get their NPI numbers. And NPI is the National Patient or National Provider Identifier, where it connects the billing structure to an individual provider. And so physicians, dentists, nurse practitioners, have these NPI numbers, but there's nothing to say an RN can't get one. And it's really quick and easy. I did it myself. I'm not billing for any, because I'm not working in clinical practice. But in order to be able to become visible to the public, visible to Congress, visible to payers, we need that number. And so I would suggest that nurses go out, get that NPI number, put it away. And as we at the national level are working on projects to demonstrate nursing value, we have nurses who already have their NPI numbers, who can connect billing, diagnosis, and codes to the work of a nurse. And this is what we have. We have a lot of data on providers and what they do and the volumes. We don't have this information because we're stuck underneath the room rate of the hospital. So those, that's what the nurse can do. Now, as an organization, as a professional organization, we're really working with Congress and CMS, the Center for Medicaid and Medicare Services, to really talk about how we need to remove nursing from, and this is looking at a hospital perspective, but looking at how we can pull the nurse out of the room rate. And when we bundle the nurse with the room, we don't see the value. And so nurses don't go to, our patients don't go to the hospital to be taken care of by physicians. They go to get nursing services. And so we need to be able to show that. That's where the revenue is coming in, is from the nurses. So if we can go back, connect the nurses, from a billing perspective, I think that will get us a long way in being able to demonstrate and show that value from a patient perspective. And I hear, it's a barrier. Well, we're going into a value-based perspective. We're going into bundling payments. That's the wrong direction. Absolutely, it's not the wrong direction because nobody else is in the room, right? So when we remove everything, we can then demonstrate the value every piece of that bundle brings to the patient care and be able to quantify it better. And then another way, with Congress, of course, and CMS unbundling that room rate, but from an outpatient ambulatory care perspective, it's looking at Medicaid and Medicare innovation projects. One thing I had worked on at OHSU was having nurses, not nurse advanced practice, but nurses bill our Medicaid program directly for the care that they were doing without a provider. And so we need to have Medicare and Medicaid get on board with creating and allowing demonstration projects to show the value nurses can do for care transitions and community, and be able to bill and demonstrate that value. There's so many things we don't need to do without a physician or a provider. And those are just some of those ways at different levels we can really advance policy together.
Right. So I want to go back to what you said about the NPI, National Provider
Identification.
So if someone is listening today and says, okay, I'm motivated, I'm going to go do that, where do they go? I have no idea. I wouldn't know where to start.
Absolutely. No, you just go in, Google National Provider Identification. You'll get the website will come up and you can go in and enter your data and then it'll spit you out a number. And so at the American Nurses Association, we were actually at the National Association for CNSs. And of course, it's an advanced practice role, but only a fraction of CNSs have an NPI. And so we realized it is kind of a hard process, or it could be a process in which doesn't necessarily make sense if you've never billed or you have no intention. But again, we need every RN and APRN, whether you are billing right now or not, to go get that NPI. And so we're working on some resources as well to come out soon to be able to help guide people through to get that NPI number.
Oh, that's great.
I was able to do it without it. Most people could figure it out.
Yeah, no, but that's great because I think it's for some, it could be really new territory, right? If you're not used to thinking about the services you provide as a registered nurse as billable services. And I think about some of our colleagues who are doing concierge nursing now, and folks don't even know that concierge nursing is a thing, but those nurses providing those services need to have that NPI. So it's all linked together, right? And then there's some other new work that's going on linking the nurse who's caring for the patient with the quality of that particular patient's outcome. So all those pieces start to become more obvious.
Yep, absolutely.
What the role of the nurse. Yeah. Yep. So talk a little bit about, now you've talked about health policy and we've talked about what nurses can do to sort of become more visible. And then we have the media, our friends and colleagues in the media. And that's one of my soapboxes. I get on it quite frequently. One of the issues is this medicine nursing piece that I'm always makes me crazy. But how do we help the media better understand? And we both know that the AP, the Associated Press guidelines, say that the only people that can be identified as RN in as a doctor in a news story are physicians and dentists. And so how do we start to change some of that visibility in the media?
Absolutely. And another great question. And I would, say many nurses may have the opportunity to talk to their press or talk to their local newspaper. I've happened, when something occurs like a natural disaster or something is going on in their community, I've seen people, media will reach out and they'll want to know if they can talk to a nurse about what's going on. And many times nurses say, I don't want to do that. I'm just a nurse, and get kind of tensed up and then need to think about it, or, think they'll respond tomorrow or the next day. When a media request comes, news is news, and what's happening now will be old news in about 2 hours. So if someone calls you and says, hey, I'd like to talk, you just take that advantage and opportunity and recognize that as a nurse, you know so much information. And so I really recommend nurses to just say yes and to be interviewed, and to let your expertise be known, and to say you are a registered nurse or an advanced practice nurse. But again, don't wait, don't sit on it. And I think a lot of their state nurses associations too, and other professional organizations, offer media training, because that's another important piece is, what do I say in an interview that doesn't get myself in trouble or get someone in trouble? And media likes, 8-second or shorter, 3 to 8 second sound bites. And so spending some time learning how to talk to media, and then proactively reach out to your local newspaper or your local TV channel and say, hey, I'm a registered nurse, and if you ever need any comments or thoughts, I'm happy to be here. Also, though, read your newspaper and write an editorial. So I have an editorial I wrote to my local newspaper, and even if we're not, and I'm at the PhD, not Dr. Jennifer Mensik Kennedy, but I'm still Dr. Jennifer Mensik Kennedy, RN. And at least at that point, people can see that, I have something to say.
Well, I also think too, the more nurses fill non-traditional roles,
Yes.
the more that whether it's working in an insurance company or whether it's working in an architectural firm, once you see nurses in these non-traditional roles, then people are like, oh, well, I didn't know a nurse could do that. I mean, I hear that all the time, having worked in some non-traditional positions. And that I think is just a very subtle, but a very effective way to start to change what it is nurses do. What do we know? What are we capable of doing? Because everyone thinks, it seems, oh, we just, follow orders and give shots or something.
Exactly. Well, and I get the whole, well, I don't work in a hospital, so I don't work in a hospital, and I haven't for a while. And they're like, well, when you were a nurse, and I'm like, no, I'm still.
I know. That's my other one. That happened, and that will happen a lot in the non-traditional roles, because they'll say, oh, when you were a nurse. It's like, no, I'm still a nurse. My brain is wired like a nurse. It's always that way.
Absolutely.
So I'm going to change the subject a little bit, talking about the workforce, right? So we've kind of talked about policy and making ourselves more visible as nurses, and you've given some great strategies and ideas about how nurses individually can do that. So let's talk about salaries, and let's talk about what's happened as a result of COVID, right? There's complete shift in this nursing workforce, and certainly there's travel nurses, and that's a piece of it. But I think a lot of nurses learned pretty quickly that they're worth a lot more than they're being paid, which is probably also tied to our first, topic we talked about. But what are we going to do? Because you listen to CFOs and CNOs, and they're lamenting there's no way they can afford a certain salary. And we did a study here at Vivian at the end of last year, and the nurses who are in our database, who are some working travel, but who are wanting to come back to permanent employment, they're looking for $61 an hour. And quite honestly, maybe they need, well, we don't know if that's just the hourly wage or total comp, but nonetheless, it's a lot more than what they're making. And so what do we do with this?
What do we do with that?
It's a huge issue.
It is a huge issue. And I think we're going to need a couple different things. We will need to go back to Congress and look at the Medicare area wage index, and that's going to have to be adjusted. And I think it's not been adjusted appropriately, probably for a very long time, because there was a recent study in the Journal of Health Affairs that said that the wages of registered nurses have increased a little over 2%. But in context, the US is currently running at the same rate at 8% year after year. So when you look at the rest of the other industries and you look at nursing, we're not keeping up with the pace of salary increases across the board. And this really became, I think, noticeable when we can't bring nursing assistants in. And if we can't have nursing assistants in because they can go to any chained restaurant and make more money per hour, we have to look at what the value is that everyone is bringing to the table, and come up and have some really good conversations that say we're going to need help at a federal, at a national, payer level in order to be able to adjust to what we need. I know people want to make a lot of money. It was funny. I was getting my hair done last week, and the person next to me was talking to the person washing their hair, and they had said they had considered going into nursing because they were quoting the travel nurse is making so much money. This person wasn't even a nurse. And so I was just listening to the conversation. So it's out not only in nursing, but it's all over about what travel nurses can make. And so I think, again, also, it's not always about salary though, too. It's about work environment. And I always tell people, if someone's going to pay you more than everyone else, it's probably because the work environment's not great and they need to incentivize people to stay for other reasons. Yeah. So at the end of the day, you might get paid less, but it's about being happy every day as opposed to happy every couple of weeks when you get your paycheck. So
right. Yeah. I mean, that's really good advice too. And I think too, nurses can often forget that total compensation, the part of their compensation that is their benefits and health insurance and things. Yep. So the last thing I want to talk about is our new graduates. New graduates have had a rough couple of years with COVID. And I know you probably looked and read the same paper I did from the National Student Nurses Association data that showed that this new cohort of graduate nurses, their number one choice for their career was travel nursing. Yep. And that just blew me away because it's always been ICU and ED and, or OB. And then all of a sudden, so what's that about?
What's that about? I think it's the thing that's in the shiny new thing that really is out there that people look at. And on social media, there's a lot of really fantastic stories that people are posting about their life as a travel nurse. But what people are not posting is all the negatives to being a travel nurse. And so I think people see it. And once you experience it, you're going to know whether or not it's there for you. I was a travel nurse when I was younger. I remember having a friend who graduated out of my program 7 years ago, who went right into travel nursing and has been a travel nurse his entire life, working 6 months on, 6 months off. And so for some people, that's just their lifestyle. He has no family, children, and so that is what it is. And so I think this also might be a good opportunity, though, for people to experience what it is they really want to do in nursing. We have all those people who are like, I'm going to go be a NICU nurse or an ICU nurse, and they get into it. And that's contributing, I think, to that 2-year turnover rate we tend to look at, is they realize they don't want to do that. So having the opportunities to travel, but at the same time, healthcare systems, hospitals, organizations can replicate that same travel experience within their organizations and do this internally as opposed to necessarily relying on external travelers. And I've known many organizations to do that. And really, eventually nurses settle into an area or a unit because eventually the travel lifestyle might get old and people just want to settle down as well. So I think it's fatty. It's on social media. We've all tried it. Many of us have tried it and done it a little bit. And so it's a good experience, but I don't think this is the future by any means.
Well, I always say this about nursing, our profession, is that it's a good thing we all don't like the same thing. Yes. Because then we would have too many of whatever. So it's a wonderful profession that we each can find our little place in the world and do our work. So not everyone is meant to be a travel nurse, and that's a good thing. And the ones that enjoy that, then that's perfect for their life. So it's one of my little words to live by. So I'm being cognizant of how much time I'm taking. Thank you very much for talking with us today. And I know, I've said this to you. I will help you with whatever I can as you're out there leading the charge. You're doing a great, great job. I know it's probably tiring and you've got a family and trying to hold down, this traveling back and forth across the country, but I just can't thank you enough for joining us today. But if you have any questions or comments or would like to know more about an NPI, reach out to us at hire.vivian.com and we will see you next time. Thank you.
Thank you.